Okay, deep divers, welcome back. Today, we're doing something a bit different, but really valuable, I think. We're diving deep into a set of revision notes you sent over, focusing right in on one specific condition, glomerulonephritis.
Yeah, think of this as your sort of high-yield pass. We're going to go through these notes together, pull out the essentials, and really try to make the key facts stick, turning that, potential information overload into focused insight for you.
Exactly. Our mission is just to unpack what's in these notes, the core ideas, the tricky bits, the must-knows. We'll hit everything, what it is, the causes, how it affects the body, how patients present, investigations, management, and the prognosis.
And it's all coming straight from this material right here.
Right.
So let's jump in. According to these notes, what exactly is glomerulonephritis at its simplest level?
Right, the notes define it very clearly. Kidney inflammation, but specifically hitting the glomeruli, those tiny filters in the kidney.
Precisely. And the notes immediately say why it's mainly driven by immune and inflammatory processes. Basically, your own immune system causing problems for those filters.
Ah, okay. So the filters get inflamed because of the immune system acting up. The notes also make a really key distinction right away, don't they? Primary versus secondary.
Yes, that's crucial. Primary means it's just the kidney involved. The GN is the main problem. Secondary means it's popping up as part of a wider systemic disease, like the notes mention lupus as a classic example there.
Got it. So kidney only versus part of a bigger picture. And these notes say it can be classified in different ways too, like by the clinical syndrome, how it looks under the microscope, or the actual cause.
Exactly. Different ways of slicing the same cake, essentially. And here's something interesting. The notes point out quite a lot of cases are actually mild, asymptomatic even. They might go completely undiagnosed.
Wow, totally asymptomatic. That's kind of surprising. Changes how you think about catching it. Okay, so if it's often immune stuff, what causes are listed in these notes? What kicks it all off?
Well, the notes give a pretty clear list. Immune system disorders themselves, which makes sense. Then infections, things like strep infections, the classic post-strep GN everyone learns about, or viruses. Autoimmune diseases, again, fitting the immune theme. Genetics can play a role, and also certain drugs and toxins are listed.
Okay, quite a mix of triggers then. So who's more likely to get this? What risk factors do the notes highlight?
It connects back nicely to the causes, really. Having autoimmune conditions like lupus or vasculitis is a big one, a history of certain infections. Exposure to those meds or toxins we mentioned, a family history of kidney disease makes you more susceptible. And, common chronic conditions like diabetes and hypertension are also listed as risk factors.
That makes sense, yeah. The risks tie back to the triggers or things that stress the kidneys anyway. Now, we've got into the mechanism, the pathophysiology. How does the immune attack actually cause the kidney problems, according to these notes?
The core idea in the notes is that this immune-mediated damage directly hits the glomeruli. That causes inflammation, and that inflammation just disrupts their main job, filtering the blood properly.
Okay, let's use that filter idea. If the glomerulus is like a super specialized sieve in the kidney, right? Letting waste and fluid out, but keeping important things like protein and blood cells in.
Exactly. Then when it gets inflamed and damaged, that sieve gets, well, leaky or clogged up. The notes are clear on the immediate results. Stuff that should stay in your blood starts leaking into the urine. So you get proteinuria protein in the urine and haematuria blood in the urine.
Ah, I see.
And at the same time, the filter isn't clearing waste and fluid efficiently anymore. So you can get reduced urine output and just generally impaired kidney function.
That leaky or clogged sieve image really works. Okay, so the notes then dive into what this damage actually looks like microscopically, the histological patterns. This bit can feel dense, but it's key. How can we break these down based on the notes to make them easier to remember?
Yeah, this is where the biopsy is so important. The notes list several distinct patterns. Think of them as different looks of the damaged filter.
Okay, let's start with minimal change disease. What's the key takeaway there from the notes?
For minimal change, the notes stress it's super common in children. Accounts for, 70 to 90% of childhood nephrotic syndrome cases. Big number. A memory hook might be minimal change, maximum impact in kids. The notes say it usually responds really well to high-dose steroids, prednisolone, which is good, but they also point out it often relapses, comes back.
Okay, minimal change, kids, responds to steroids but relapses often.
Got it.
What about FSGS, focal segmental glomerulosclerosis?
FSGS, the notes say, is more common in older kids and young adults. And here's a really important contrast to minimal change. The notes state up to 80% are resistant to steroids, so a memory hook. FSGS for steroids, generally stubborn. Alternatives like cyclophosphamide are mentioned.
That steroid resistance is a huge difference. Definitely a point to remember. Membranous nephropathy.
This one, the notes say, is often idiopathic cause unknown, but importantly, it can be secondary, linked to other things. The treatment approach highlighted is either conservative watching or alternating treatments.
Okay. Mesangiocapillary glomerulonephritis, or MCGN.
The notes specifically link MCGN with low C3 complement levels. So memory hook, MCGN, think low C3. Secondary forms are tied to infections or SLE. Treatment mentioned here involves ACE inhibitors or ARBs.
Let's just quickly touch on those ACE inhibitors, ARBs, common drugs. What are they actually doing here? Why use them in GN based on these notes?
Good question. The notes don't go into massive detail, but fundamentally ACE inhibitors and ARBs help in a couple of ways here. They can reduce the amount of protein leaking into the urine, which is a major problem, and they help control blood pressure. Both are key goals in managing GN, as the notes point out elsewhere, so they offer kidney protection in that sense.
Right, kidney protective. Thanks. Back to the patterns mesangial proliferative nephritis.
This pattern, the notes state, is common in IgA nephropathy. It can show up in different ways, just haematuria, maybe proteinuria, or even full-blown nephrotic syndrome. Immunosuppressants are mentioned if kidney function is getting worse.
Okay. Diffuse proliferative glomerulonephritis.
The notes link this one to infections, SLE, or post-strep GN. And there's a really important point about prognosis highlighted. Children often recover well from this pattern, but adults are more likely to develop chronic kidney problems. So, memory hook, diffuse proliferative, different prognosis for kids versus adults.
Focal segmental proliferative glomerulonephritis.
Notes say this is usually secondary to systemic diseases or infections. They specifically mention abnormal proteins damaging that filter barrier we talked about earlier.
And the last one on the list, crescentic glomerulonephritis. What's the big deal with this one, according to the notes?
The key feature is the formation of crescents in the glomeruli, visible on biopsy. This pattern often shows up when primary GN gets really bad, or in specific syndromes. And crucially, clinically, it presents as rapidly progressive glomerulonephritis RPGN. Kidney function goes downhill very fast, memory hook. Crescentic C for crescents, C for crash course in kidney decline.
That's really helpful walkthrough of those patterns. It definitely shows why you often need that biopsy. So just to lock this section down based on the notes, which patterns are most strongly linked with kids?
Minimal change disease is the standout one for kids, particularly presenting with nephrotic syndrome. FSGS is also mentioned as common in older children and young adults.
Okay, and which one did the notes flag as often being resistant to steroids?
That was FSGS, with up to 80% resistance mentioned.
Perfect. Highlighting those kinds of associations really helps. Now, Goodpasture syndrome gets its own mention. What's the defining thing there according to these notes?
The absolute key, mentioned right away, is autoantibodies against the glomerular basement membrane itself. So antibodies attacking the kidney's filter structure.
And how does it typically present?
The notes describe a really serious combination. Bleeding in the lungs, pulmonary hemorrhage, and rapidly progressive GN. It's both lungs and kidneys hard.
Sounds incredibly urgent. And the treatment listed.
It's a combination approach outlined in the notes. High-dose steroids like prednisolone, an immunosuppressant like cyclophosphamide, and plasma exchange, physically removing those damaging antibodies from the blood.
Okay, let's shift slightly. The notes touch on differential diagnoses, things that might look similar. What's on that list?
It's a short list, but important. Acute interstitial nephritis, diabetic nephropathy, and SLE nephritis are the key ones mentioned to keep in mind.
And just quickly on epidemiology, the UK data provided here. Who gets this and how common is it?
Notes say it affects all ages, though certain types are more common in younger people. The prevalence figure given is about 3 to 4 new cases per 100,000 people per year in the UK. So not extremely common, but definitely something clinicians will encounter.
Okay, let's circle back to the patient. What does glomerulonephritis actually look or feel like? What are the clinical features the notes list?
Well, the notes give the general signs and symptoms first. You might see haematuria, blood in the urine, sometimes visible, sometimes not. Proteinuria, protein leakage. Edema, swelling, classically starting around the eyes or in the ankles. Hypertension, high blood pressure. Sometimes decreased urine output.
Yeah.
And often fatigue, just feeling wiped out.
And these general signs often group together into specific clinical syndromes, right? The notes really emphasize these because they guide how you think about the patient initially. Let's run through those main syndromes again.
Exactly. The notes lay out 5 key presentations.
Asymptomatic haematuria and neuroproteinuria. Like we said, just found on a routine test, no symptoms.
Nephrotic syndrome. The hallmarks here, according to the notes, are heavy proteinuria, which leads to low protein in the blood, hypobuminemia, causing significant fluid retention, and that classic edema. Memory hook. Nephrotic. Lots of protein loss.
Nephritic syndrome. This usually involves haematuria, often visible blood, some proteinuria, less than nephrotic, reduced GFR, so kidney function is down salt and water retention, and hypertension, memory hook. Nephritic, inflammation, impaired function, increased BP. More about inflammation signs than just massive protein leakage.
Rapidly progressive glomerulonephritis, or PGN. This is defined by that fast decline in kidney function, weeks to months. Very serious, often linked to that crescentic pattern.
Chronic glomerulonephritis. This is the slow burn. Gradual loss of function over years, typically with ongoing hematuria, proteinuria, and hypertension. The long-term result of some progressive types.
Those 5 are really key clinical pictures to have in mind. So, quick check based on the notes. Patient comes in, they're quite swollen. Urine dipstick shows loads of protein. Bloods show low albumin. Which syndrome are you thinking of straight away based on those notes?
Yeah, that combination, the heavy protein loss, low albumin in the blood, and the resulting edema that directly matches the definition of nephrotic syndrome given in these notes.
Perfect. Recognizing those clusters is key. Okay, so you suspect GN. How do you confirm it and figure out the type? What investigations do the notes list?
The notes outline a pretty standard workup. Starts with urine analysis dipstick, microscopy looking for cells or casts, and often a 24-hour urine collection to actually measure how much protein is being lost.
Makes sense. Check what's coming out of the faulty filter. What about overall kidney function?
That's measured by the glomerular filtration rate, GFR. The notes mention using the estimated GFR, eGFR, from blood tests, or sometimes the Cockcroft and Gault calculation.
And blood tests besides just the kidney function numbers?
Yeah, a whole panel is listed. Full blood count, inflammatory markers like ESR, CRP, the kidney function tests, urea, creatinine, electrolytes, liver function, glucose. And really importantly, the notes stress immunological tests looking for those specific antibodies or complement levels that hint at an immune cause.
Any other tests mentioned?
Yes, checking for infections, HBsAg for Hep B, anti-HCV for Hep C, ASOT for recent strep. Radiology is usually involved a renal ultrasound to see the kidney size and structure, maybe check for obstruction, and sometimes a chest x-ray, especially if you're worried about something like Goodpastures affecting the lungs.
And the definitive step, the one that tells you exactly which type it is, linking back to those histological patterns we discussed.
That's generally the renal biopsy. The notes say this is usually done because looking at the tissue itself is the best way to nail down the exact pattern, and that really guides the treatment. Though they do mention exceptions might not do it in very mild cases or in a child with classic nephrotic syndrome where you strongly suspect minimal change disease anyway.
Right, the biopsy ties it all together. Which leads us to management. What are the goals and general approaches for treating glomerulonephritis, according to these notes?
The notes state the goals clearly. Control the symptoms, slow down the kidney damage progression, and prevent complications down the line.
And how do we do that? What tools are listed?
The main approaches involve medications. Corticosteroids and other immunosuppressants are key for calming that immune attack. Then drugs like ACE inhibitors or ARBs, which we talked about, to lower protein loss and control blood pressure. Dietary changes are mentioned, like salt restriction. Strict blood pressure control is really emphasized, obviously treating any underlying cause if it's secondary GN. And managing cholesterol, often with statins, is also on the list. Plus, monitoring the hematuria and proteinuria.
So treat the cause, protect the kidney, manage symptoms. What about more specific treatments?
Yeah, the notes make a point that treatment is very tailored. Depends heavily on the specific type of GN and what the biopsy shows. It might involve specific immunosuppressive drugs, maybe biologics like rituximab in some cases, sometimes antithrombotics to prevent clots, especially in nephrotic syndrome, or even IV immunoglobulin.
And if things progress despite treatment and the kidneys fail?
Then the options mentioned are dialysis or a kidney transplant.
Okay, finally, let's look at the long view prognosis and potential complications. What do these notes tell us about what someone with GN might expect?
The notes are clear that the prognosis is highly variable. Really depends on the cause, how bad the damage is when caught, and how well treatment works. Outcomes can range from complete recovery in some types, all the way to chronic kidney disease or even end-stage kidney failure. And the complications listed are pretty significant. Hypertension is a big one, both a symptom and a complication, fluid overload, electrolyte problems, and importantly, an increased risk of cardiovascular disease, heart attacks, strokes. The notes really hammer home that blood pressure control is vital because it directly impacts kidney progression and these cardiovascular risks.
It's quite stark that the notes state glomerulonephritis is a common cause of end-stage kidney disease.
It really underlines the potential seriousness, doesn't it? Even if some cases start silently. The notes also mention specific risks with nephrotic syndrome, like blood clots, those thrombotic episodes, and being more prone to certain infections, particularly pneumococcal infections.
So thinking about everything we've just pulled from these notes, especially those complications, hypertension, fluid issues, cardiovascular risk, what's the one thing, the one parameter you'd absolutely want to monitor and manage super tightly in someone with GN?
Oh, definitely blood pressure. Based on how often it's mentioned in these notes, its role in driving progression, and its link to major complications, tight blood pressure control seems paramount.
Makes total sense. Seems like a critical lever to pull. Well, that was a really thorough run-through of these glomerulonephritis revision notes.
Yeah, we've covered a lot of ground: definition, causes, risks, the different ways it damages the kidney, the clinical syndromes, investigations, treatments, and the potential outcomes and complications, all drawn straight from the notes provided.
Hopefully breaking it down like this, piece by piece, pulling out those key associations and facts highlighted in the notes, helps make this complex topic feel a bit more manageable and more recallable for you.
Absolutely. And it really reinforces that point from the start about the huge spectrum of this condition, from totally silent to causing end-stage kidney disease.
Yeah.
Understanding that diversity, which comes through clearly in these notes, is so important.
Definitely. And if this style of deep dive into revision material works for you, you might find resources like pastamtepare.com and freemetsray.com useful for continuing to build and test that high-yield knowledge.
Yeah, they're great tools for consolidating this kind of essential information.
Thanks for joining us for this deep dive into your glomerulonephritis revision notes.